So my name is Laura Mae-Baldwin, and I'm a family physician at the University of Washington, been there for a long time. And I am someone who has, some of my work over the last, I'd say, decade has been as I've directed what's called a practice-based research network. A practice-based research network is a group of practices that is willing to collaborate with researchers to answer questions that are important to primary care. And so we have these clinics all over the Washington, Wyoming, Alaska, Montana, Idaho area, the WWAMI area. And one of the researchers who came to us and wanted to do some work in primary care is named Michael Parchman. I'll tell you a little bit more about him in a moment, but he's up there. He's from Kaiser Permanente, Washington. And he had some ideas about how to help manage opioids in primary care practice, and came to us to say, hey, do you have any practices that would be interested? And we had a lot of practices that were interested for obvious reasons. So I'm going to tell you about the program that we've developed and how it has been interfacing with Accountable Communities for Health in the state, and also with the Department of Health, as well as others. And we'll see if there's any synergy. So Brooke EK is also a member of our team. She's a practice coach who works with our group and worked with the research that we did that I'll tell you a little bit more about. So am I controlling moving this forward? Do I just push this button?
Oh, no, I'm sorry. I did not give you the right one.
What's that?
And then this.
Oh, okay. I did need something else. Change. Okay. Oh, there we are. Okay, so there I am up at the top. That's Brooke EK, and Nicole Ide is another practice coach. Actually, Nicole and I were just up in Chihuahua. So it just so happened that we were in Chihuahua this afternoon, or this morning, and last night, actually working with them on the 6 Building Blocks program. And that's Michael Parchman from Kaiser Permanente, Washington. He's really the mastermind for all of this. So I'm going to just say a little bit. You probably don't need to know the first part of this, which is what's the current state of the prescription opioid crisis. But many of you actually are working more in addiction, perhaps with heroin and so forth. But I'm going to talk more about prescription opioids because that's really the world that I live in with primary care clinics. And it's really shocking. So, you know, it's always a reminder when I go over these slides to look at that. Then I'll tell you a little bit about how the 6 Building Blocks came to be. And talk a little bit about what the relationship is currently with the 6 Building Blocks and Accountable Communities of Health. And then I think part of the discussion is whether the 6 Building Blocks would be useful to Better Health Together and its partners. So every year, more Americans die from prescription drug overdose than they actually do from heroin and cocaine combined. Even though in the US we have only 5% of the world's population, we consume 80% of the world's opioids. This is kind of the bummer part of the talk. It's really sad. 4 out of 5 heroin users, someone was talking about this, actually started with prescription opioids. And 115 Americans die every day from opioid overdose. That includes both prescription opioids and heroin. But 46 Americans die from prescription prescription opioid overdoses every day. That's a lot of people. And in Washington State, annually, there are 65 opioid prescriptions written for every 100 people. So we are not immune from this problem whatsoever.
How does that rank with those states?
That's a good question. I didn't pull out all the other states, so I can't tell you. But I do have the reference for that, so we could look it up. It's from the CDC. I think that, you know, we know that places like New Mexico and kind of the Appalachian area.
Ohio. I have a lot of family in Ohio.
Yeah. I mean, I can bet you that they're higher than we are. But actually, if you look at, I actually did look at sort of some of the counties in Better Health Together, and most of them are higher than 65. So Stevens, I think, is 80 to, I don't have it right off the top of my head, all the other ones, but there are some that are higher. So we have a deep hole that we've dug. We didn't really dig it ourselves completely. We got a lot of help. You know, I'm pretty old, so when I started practicing, they didn't prescribe opioids for chronic pain. It just wasn't part of the culture of medicine. And then for people who are old enough to have remembered the fifth vital sign, there's something called the fifth vital sign, which was you gave every patient a little scale, like a happy face and a sad face, and they told you how much pain they were having. And Purdue Pharmaceuticals convinced through, I think a lot of shady dealings, that we should be prescribing their medications, which included OxyContin. So we came by this, in a very difficult way, but what you can see now is that 40% of all U.S. opioid overdose deaths involve a prescription opioid, and it has continued to accelerate. There have been some improvements in the last few years since this has gotten attention, but the rates are still so much higher than they were in the early 2000s. It's just really problematic. Opioid deaths in Washington State from 2004 to 2016 also increased. And this actually looks at the risk of opioid overdose based on your morphine equivalent dosing. So morphine equivalent dosing is how you can take any opioid medication that's prescribed and kind of standardize it to a certain kind of unit, which we call a morphine equivalent dose. And so here, at using the standard of under 20 morphine equivalent dosing and then comparing higher doses, you can see that folks who are on 20 to 50 morphine equivalent doses have 1.4 times higher risk of opioid overdose, and then 50 to 100, 3.7, and then over 100, almost 9 times the risk of opioid overdose, which is where some of the numbers have come from the CDC and Washington State that have identified these very high rates of overdose and the requirements for having consultation at those high doses. And if you look at death from opioid overdose, it pretty much parallels this. Oh, this one didn't come out right. I don't know why. It looked okay before, but anyway. The top 5 medications prescribed in the U.S. in 2016, hydrocodone acetaminophen, which is just one type of opioid, is the fourth most common medication behind thyroid medication, a blood pressure medication, and a statin. Lots and lots of prescribing going on. So something needs to happen, right? And I'm going to tell you about sort of how the 6 building blocks came about. And this really, they came about by learning from practices that were addressing this head on. So there was a program called Learning from Effective Ambulatory Practices. This was Michael Parchman's project. It's actually funded by the Robert Wood Johnson Foundation. And what this project was, is they were actually not looking at opioids at all. They were looking at practices that had been nominated as exemplary for their team-based care and the way that they employed teams in quality improvement. And what their team did, what Michael's team did, was they went to these 30 sites all across the country, many of which are sites in rural places. And they spent a week in those practices, just talking to people, looking at what was happening, understanding how are they doing this fantastic job of team-based care. And what they found is that 2/3 of those practices were addressing opioids through this team-based approach. And this was back in the mid-2015 or so, 2000. So they were early in the curve. And so Michael then came to us and came to some of his colleagues and said, I want to learn from this. So we did a qualitative analysis of the notes that they had taken on these 30 visits and identified the commonalities, like what were they doing that seemed to be working for them in managing opioids. And out of that, created this 6 building blocks for safer opioid management. And that was published in the Journal of the American Board of Family Medicine in February of 2017. And so what are the 6 building blocks? So what did these practices, what were they all doing that was so successful for them? So I'll just run through these 6 building blocks and then I'll talk to you about how we actually have implemented those and studied them. So the first one is leadership and consensus. I don't think these things will actually probably surprise you. I mean, you know that having good leadership support, building organization-wide consensus to prioritize an issue that's of importance. I mean, that makes a lot of sense, right? But what these organizations did was they said, their leadership said, we are going to prioritize more selective and more cautious opioid prescribing. They also all tackled their policies, their patient agreements, and their workflows. They basically sat down, and this was actually before the CDC guidelines came out, so they were kind of putting these policies and procedures in place before they even had a roadmap, which was pretty impressive. So they revised their clinic policies, they revised their patient agreements, and then, importantly, first they aligned those two, they aligned their policies and patient agreements, so what they said they wanted to do, they actually told the patients, this is how we're doing it now. And then, super importantly, they created workflows so that everybody knew, everyone on the team knew what their role was to make sure that they were following through on the policies. Absolutely critical. The third thing that almost all of them did was they came up with a system to track and monitor. And I know that that's something that's happening through the ACHs too, this tracking and monitoring. There's a real emphasis on this. They were able, through, many of them put into place registries of some sort of their chronic opioid patients, but they were all creative. They had to use their own systems. And as those of you who know electronic health record systems, they are not very cooperative much of the time. So they had to be creative in how they did that. But that allowed them, by having some registries and tracking and monitoring systems, to do population management. So they weren't just managing these patients when they came into the clinic, they were also coming up with ways that before folks came in, they were prepping for those visits. In between their clinic visits, they were identifying patients who had certain needs and managing them in all ways.
I just realized the issue was with that previous slide was in the way that we combine the two. So if you just give me one moment,
oh sure,
I can get you to this to the right,
okay,
and we can
avoid
that issue.
So what was it that?
Basically, put the two slide decks together.
Oh,
and it just kind of pushed it up incorrectly. So
I've seen that before, like sometimes between a Mac and a PC, because I use Mac. So
I think this should remedy it. So I'm just going to switch over.
this is a beautiful space, by the way. Is this
It is.
It's the Philanthropy Center? I mean, it was that like, is that something that someone many years ago just thought?
This used to be the old Chamber of Commerce, and it sat empty for about 10 or 12 years.
Okay.
The Empire Health Foundation bought the building and remodeled.
Okay.
So
Yeah, it's really beautiful. This whole series of buildings is beautiful. Really. Okay. So the second three building blocks, the next is planned patient-centered visits. This has a lot to do, some of the tracking and monitoring really feeds into this, but, and not all of you are clinicians, so you may not appreciate this from a primary care perspective, but when we see patients in our clinics, we often do what we call a huddle in before our clinic or early in the day, so that we kind of look at the landscape of who are the people that are coming in and what do they need and how can the medical assistant or the nurse that I'm working with actually help prep for my visit. And that saves me time as a primary care provider, and it helps the team actually participate in the care of the patient. So doing that, preparing and planning for the clinic visits of patients on chronic opioid therapy, and then also supporting these clinics, we're also supporting empathic communication. Being on chronic pain medications, many patients feel stigmatized by that experience. Many providers have made them feel stigmatized to be on chronic pain medications. And at the same time, many of us also feel very uncomfortable with the amount of opioid medications that they're receiving. So coming up with a way to actually talk with your patients empathically, and at the same time change a behavior that's very difficult is really important and quite difficult. So, but these clinics had developed scripts, actually, that they used with their patients. How can we encourage our providers to talk with their patients in a way that's respectful, empathic, and still gets them to a safer place with their opioids? Some of these patients are addicted. Some of them have other mental or behavioral health problems that are getting in their way of managing their lives and also tapering their opioids. And so making sure most of these clinics had policies and resources that they either created within their own clinics, because some of them were really tiny clinics that didn't have a lot of resources in their community. So they created some really creative, or created some really innovative programs, or they identified what resources were out in their community for referral for behavioral health concerns or for opioid use disorder. Some of them took on prescribing buprenorphine or Suboxone themselves. But having a plan was very important. And finally, being able to measure what they've done. Like, are we doing the right thing? Do we need to make adjustments to our program? So these were the 6 building blocks. And as I said, this is what the clinics were doing. We learned from them and just kind of put it together in an organized fashion. So what Michael then did in collaboration with our clinical network, and we had 20 clinics that volunteered to participate in a research study to implement these 6 building blocks. And they were in Eastern Washington and Central Idaho, these clinics. And we studied kind of what it was like for these clinics to implement the program, but we also looked at how are they doing with their 6 building blocks. So we have an assessment, a self-assessment, and they fill it out at the beginning of the program, and then we follow it all along to see if they're making progress. And indeed, what we found is in this implementation, they were able to improve their building block scores quite substantially. And when we studied the clinicians that were in these clinics that had the higher building block scores, they were clearly more confident and more comfortable with the management of these patients. So we were very encouraged by that. We are currently looking at the morphine equivalent dosing of patients and the numbers of patients and whether they were actually able to taper patients off or whether they were able to decrease the load of morphine equivalent dosing in their clinic. And our biostatistician hasn't allowed us to release the data, but they look very promising. Here's what one clinician said about how he felt after the implementation of this project. He said, having a defined care pathway for an emotionally charged and complex area of care, it's like walking in with a plan. It's like walking into the emergency room and somebody's having a cardiac arrest. It's actually not the most stressful thing I do because I know exactly what to do. And those of you who are providers in the room can probably relate to this. It's like, it's formulaic. It's consistent. You know exactly what the plan is. Now, this provider said, I have the same kind of pathway for opioids. And so having what we're going to do defined is just so helpful. So we're at the end of this project, and we've started to disseminate it. And it's been very, very rewarding. The Oregon Prescription Drug Overdose Project has adopted the 6 building blocks. The CDC has a chronic pain guidelines implementation project that has incorporated the 6 building blocks. And we presented it at numerous conferences locally, regionally, and nationally, which has been just very rewarding, and held workshops for providers. And so as we were getting the news out there, and when the accountable communities of health were starting to form, we got a call from the Olympic community, I think it's called the Olympic Communities of Health, and they had been actually doing quite a bit of work around opioid management through some prevention work groups that they had. And so they had made quite a bit of progress in this regard, and they approached us to learn about the work. And it was through that we actually learned about the Medicaid transformation plan and the fact that it has a required, just like you were talking about the integrating behavioral health and primary care, it also has a required opioid project. And part of those requirements include some of those bullets that they wanted the ACHs to include were just right up this alley. So they included things like promoting use of best practices among healthcare providers, building provider capacity to recognize signs of opioid misuse, screening for opioid use disorder, linking patients to treatment, and then enhancing efforts to monitor opioid use. So when we saw this, we went, wow, this is just an incredible fit. So we've continued to work with the Olympic Community of Health. And they were quite interested in this idea of perhaps statewide being able to have an approach to working with patients in primary care and other settings actually as well too, to help manage opioids more effectively. So we gave a webinar that was actually sponsored by the Olympic Communities of Health back in June when the applications were going in for the ACH. And as a result of that, 7 of the 9 ACHs actually talked about using the 6 building blocks as a component of their opioid project work in the proposals. And so we are now going back to the ACHs to say, okay, you're getting started. Do you want to be using this approach or not? And so part of what I think I am interested in learning from you about, and this may be part of the group that we really need to talk to, maybe not all the group, is whether this approach would be helpful in some of your settings and for some of the partners. So, so there are 3 possible strategies for how to integrate the 6 building blocks into ACHs. One is something that we used in our research study, and also something that we are doing with the Department of Health, which is providing tailored direct facilitation to individual clinical organizations. So, you know, we have worked with organizations across the state. We actually have practice coaches, and I'll describe to you exactly how we do this work. But we actually do some of that work. The other strategy that we would love to try is actually a train-the-trainer approach, because there are larger organizations. So, for example, like Rockwood, or maybe even your organization, you might have some capacity within your organizations to do this work, or to do some of the practice coaching. You might have quality people or something like that. And so you wouldn't necessarily need someone who would come in and do the practice coaching, but you might have someone who you'd want to train to do that and then work with your organizations. So that's another approach. And then there's a hybrid, because we learned that sometimes there are large organizations that have QI resources, and sometimes there's small organizations that don't have a lot of QI resources. They're not going to have the capacity to do the coaching themselves. So what would happen if in the tailored direct facilitation program is that, and this is what we are using with OCH, with the Olympic Communities of Health, is we're identifying, they are actually identifying who wants to participate, who are the clinics and organizations that want to participate. We then go in and learn what those organizations are actually doing already in regards to opioid management, and then tailor the 6 building blocks to them. The ACH, I think, has a wonderful opportunity to develop either ACH-wide or community-wide metrics. Like, what are our goals? Where do we want to get to? What do we want to put into place? And then aligning the reporting that you all are doing with the 6 building blocks. And then the building blocks program itself, if we were doing the direct coaching, we have a team of physicians, a practice coach, pain specialist resources. And so here's what actually takes place in this program. It's basically a 15-month program where each site creates an opioid quality improvement team. That's usually a provider, like a provider leader, some kind of quality person, and someone who has control of the data, who can actually produce reports. We then will go in and do a team building kickoff event with the clinic. What happens at that is they do a self-assessment of where they're at with the 6 building blocks. So they look at themselves and they say, how are you doing on these 6, in these 6 domains? And they do that with staff, front desk staff, back office staff, administration, providers, because this is really a team approach. It's a way that everyone needs to be on board with this. And I would say this is actually the most important part of the whole program, because it gets everyone on board, it gets them excited, it gets them talking. We've had some sites say, this is the first time that our staff have actually talked about an issue with our providers and felt empowered to do so. It's really exciting to be in those. And then there's this continuing sort of coaching around revision of policies and treatment agreements. We actually have a model policy, a model treatment agreement, creating workflows that support whatever policies the sites put into place, developing a tracking and monitoring approach. So we actually have a very simple Excel tracking sheet that we can provide to clinics. Many clinics, particularly those that have more resources, are able to create their own registries for their own ways of tracking, which is fantastic, but we help the sites actually figure out, well, what do you want to track and how are you going to, where are you going to find those data and how are you going to use those data? There are patient education efforts that they work on. And then we have monthly shared learning calls. These are really fun because the sites actually get together and talk about what they're working on and what they're succeeding at and what is really, really hard. And they learn from each other. Basically, they're teaching each other. And then there are also telepain conferences. If you don't know about this now, it's really, they're fantastic. They're basically weekly conferences on Wednesdays at noon, where any provider from across the state can get on the line. It's a video conference. They get a very short didactic presentation about some aspect related to pain, and then they have a chance to consult with a group of pain specialists, primary care specialists, psychiatrists. They get this amazing sort of support system for the work they're trying to do. There's also a UW-based pain opioid management hotline, and I hope I have those slides here. If I don't, I can get them to you. So how would that differ from Train the Trainer? So Train the Trainer, basically, it's very similar. The first steps are really very similar. There's kind of a needs assessment, adapting, planning, but really, again, these are going to be, for the most part, larger organizations, where the larger organizations would need to look at what their resources are, how they could work with this program, what the quality resources are that they have in place that could dovetail with this. And again, talking about metrics and measures. And then we envision that there would be a one-day kind of launch workshop with ACH leaders, clinical organizational representatives, so they might be the QI folks who come to this, introduce the 6 building blocks, show them how you do the self-assessment, how to use the website that we've created that I'll show you, and then kind of talk about what the proposed implementation plan is. And then the Train the Trainer program itself would involve a few workshops with quality improvement leads over 6 months to train them in being basically coaches for the 6 building blocks. And then they would have their own learning, shared learning calls. So the trainers, or the folks who are in the QI positions in these larger organizations, would get together weekly initially and then monthly, so that they could talk about how is their work trying to implement the 6 building blocks in their larger organization going, with one-on-one meetings with our QI leads over the 15 months. And then, of course, the hybrid program would be large organizations get the Train the Trainer, and then smaller organizations could get direct facilitation. So I wanted to share this. Is it possible to actually get into this website? I would love.
Absolutely.
Okay, great. So we have a website. It's called improvingopioidcare.org. It's brand new. We're really excited about it. And these are the kinds of resources that we have in place. So, yeah, so what you can see on the, well, I don't know if you can see it up on the top, you can see that this is the home page, and then we've got the 6 building blocks. So can you just click on the 6 building blocks?
And you actually have a laser pointer on that.
Oh, I can do that?
Yeah, you want to direct it.
Oh, my laser pointer. Uh-oh.
The green light.
The green light?
The green line.
Oh, the green line. Oh, wow. And I can just click on that?
Well, you can't click, but you can point where you want me to.
Oh. I was going to say, wow, technology's really come a long way.
We're not there yet.
Okay.
It's a very nice building.
Wow, yeah, okay. So I'm kind of, a little behind the times, so I'm sure, why not? Things are changing all the time. So this is just an overview of the 6 building blocks. All right, now I'm going to use my pointer. There we go, self-assessment. So this actually, let's see, okay, download. So this, we actually have a self-assessment that we administer. It has, I think, about 19 items that, oh, maybe this is going to take too long. Maybe this is not.
Shouldn't take that long.
Shouldn't take that long.
No,
okay. It has 19 items in which the sites actually go through. So this one is the page on leadership and consensus, and it basically takes the site, and you can imagine a group of staff with providers sitting down, and one of them is reading this off. One of them is saying, the commitment of the leadership in this clinic to improving management of patients on chronic opioid therapy is either not visible or communicated, is rarely visible, and communication about the use of opioids for chronic pain is ad hoc and informal, and so on and so forth. And so it's an amazing conversation because I can tell you that most of the time providers rank things much higher than staff do. And that is a real eye-opener for providers, and it's a real eye-opener for administration, because they're realizing that there's some mismatch going on here, that the experience of these patients and of the way they manage opioids is really different. And it's incredibly important. So for each of the building blocks, we have several assessment elements. Okay, we can go back to the slideshow, or not the slideshow, the website. If you go up to implementation guide, I don't think I need to use the pointer. You figured out where all that stuff is.
We got good communication.
We talk about here, we actually have a guide with a workbook that is meant to be used by a practice facilitator or a practice coach. I suppose if you had an incredibly motivated person who had lots of influence and they wanted to take this on, you could go here independently and download the workbook and work your way through it. But it's really meant to be a guided program because you know what it's like. I mean, to do any kind of quality work, you really need someone who's very intentional, who's guiding the process and engaging everyone in the process. And so it has 3 stages: preparing and launching in the first couple of months, which culminates in the kickoff event, and then a very long time period, which is the redesigning and implementing across the practice, and then this kind of plan for how to monitor, how to sustain the program. And each of those has its own, sort of workbook format. You can go back up to the top now and click on helpful resources, because this is something that you could take right now and use some of. So you can see that on the left-hand side, there are resources for clinics, and then there are recommended assessments and resources for practice coaches. So the resources for clinics, let's go ahead and click on that on the left-hand side. Oh yeah, we're right there too. There are many ways to get to this. So again, it's organized by building blocks. So you can see that each of the building blocks has different resources that are associated with it. So if you go to this, you'll find out, how to get to, for leadership and consensus, how to get to UW telepain. So if you were interested in the telepain, you could get there through this way. And if you can just kind of move it up or down, however it works for you. So you can see under policies and patient agreements, we have a model policy that's on the site that's based on the 6, actually, can you just, not quite so much.
Okay.
Yeah. Stay on the yellow one up above. First. Uh-oh.
Just kidding.
Uh-oh.
We're doing good.
All right, there we go. Yeah, just yellow. There we go. So this is based on the CDC guidelines. So what's in the CDC guidelines has been translated into policies here. We have the CDC guidelines here, as well as the VA opioid taper decision tool. It's an excellent resource for tapering, and so forth and so on. We've got for sites that are that have their own resources, and they just need to figure out which of the opioids, which of the sedatives that they want to track. We've got lists of opioid names and lists of sedative names, and then now you can other way. Can you go the other way?
Mm-hmm. Go back.
No, just go to the bottom.
Go to the bottom.
There we go. Okay. We've got something like completely love, which is we've got this tips for difficult conversations. These are scripts. How do you tell someone something like, we used to think that opioids were safe, and we now realize that they really aren't as safe as we thought. And I'm actually really concerned about how much opioids are on. And that's why I need to bring up with you, this concern that I have and what we're going to do about it. And so there are lots of scripts like that help you kind of have these conversations. And there's even a video vignette of a wonderful provider, Erin Krebs, who's from the Midwest, who has, with one of her staff actually, has done a video of an extremely recalcitrant patient who doesn't want to taper. And her way of helping that patient get to taper in a very patient-centered way. So it's really pretty inspirational, actually. Okay, we can go back now. Go to recommended assessments. So we also have here the kinds of assessments that we recommend with the frequency. for when you're putting your policies into place, with some of the evidence behind each of the recommendations when there is evidence, and not all things are evidence-based that are recommended even in the CDC guidelines. And then if you go to resources for practice coaches, for the train the trainer, we actually have a number of things that can be used by QI type folks for actually logging the work that they're doing. So now we can go back to the main presentation. So that gives you kind of a feeling for all the kinds of resources that we've put together to make let's see. Yeah, we've got a long way to go. That's not where we were. We were way down.
We were way down. Oh, you know what? We're in the wrong, wrong one.
We were a long way from there.
Here we go. Let's try.
Yeah, there we go. Okay. Yeah. So I think we're at the end. Let's see. Yeah. Okay. Now I'm in control. So let's see. So I guess I'll just stop here for a minute. I do have a couple last slides, and just see if anybody has any questions or whether this seems relevant. I know that for some of you who are in treatment programs, this may not feel as relevant to you specifically, but I'd be interested in hearing, kind of.
The work of Greg, we don't actually do medication prescribing, but we have to work closely with the prescribers.
So do you think this would be something that would be helpful for those prescribers? Yeah. Yeah. Questions or? What about Rockwood? Where are you at with this?
I think this would be super helpful. We've been aware of the telehealth team thing, but it is sort of individuals. Some individual providers who may need to have a bigger patient population or more of an interest in that population, take advantage of some of the resources that we do know about that are offered to the University of Washington or AFP or whatever. But I think what would really be more impactful is to really bring the program to the whole clinic.
A systems approach.
The whole training piece and the scripting, I think, would be super, super helpful.
Yeah.
I think that those conversations, and not everybody we're seeing is in that situation. Of a Medicare patient dying of heart failure, and then you have the pain med person on, and because it's naturally so diverse in your day, it's a barrier to having this. But if you have all those steps, that pathway, like you described, that plan, if it's clear, the providers feel supported, they have the time and tools that they need to be able to do a really good job, to be able to track and monitor with those kind of tools, that would really elevate what we're able to do.
Yeah, that's very eloquently said, and I think that that's exactly when we go back to sites, what they say is the consistency has changed the entire feeling across our clinic. We had chaos before, and there's now order, and it just feels so good. And ultimately this is about the patient, right? This is about improving care for patients. But you cannot improve care for patients if your clinical setting is chaotic and troubled by this, and folks are burning out.
That comment about the staff and other teammates working on this is really, really important, because your MAs or your front desk or people on the phone are really getting the brunt of sometimes very unpleasant behavior. And if they don't have the tools, or if they don't feel supported, that makes their job that much more difficult.
Yep.
It really creates that barrier where there's not a lot of prescribers, because not only do you not want to deal with it as a provider, but you don't want your staff on the line, exposed to that, because their jobs are
And we run into that sometimes calling around, and, oh no, we don't see that person anymore. No, we don't.
Yeah.
No, I personally discharged many a person who, if you make my front desk staff cry, I don't care how much banana bread you bring me. If you make my front desk staff cry, I can't see you anymore. It's not, it's, I'm sorry, I'm not going to be able to see the rest of my patients if that front desk person doesn't come to work tomorrow.
Yeah, yeah, that is so, so true. And I think that's the thing I love about this team-based approach is that everyone has a role and everyone is honored for that role. And because of that, everyone is willing to step up and take on those roles. So it's really, really important. What about others? I don't know about Chaz. Can you tell me? I don't know what Chaz is. Is it a primary care setting? Okay.
Yeah. So currently, actually, we're hiring RNs to do chronic care management. And I think this conversation is coming at a perfect time for that because now our providers are looking at their clinic and trying to figure it out. And so this is, I think, a natural step to probably help that team and make it that much better.
Yeah. Yeah, so that's a great point. So you can have these care managers. In fact, care managers are wonderful ways of doing some of that tracking and monitoring and doing that between visit care. And you know what some of our clinics have done is created registries that have green, yellow, red. And so you know, when does someone need a urine drug test? Has the PMP been checked in the last few months? Is there an up-to-date patient agreement in place? What is the MED? What is the morphine equivalent dosing for these patients? You know, I think that when providers actually see what their morphine equivalent dosing is, it is sometimes a shock. And particularly if clinics are still using methadone as a treatment option for pain for their patients. Methadone has a very different set of pharmacokinetics than other pain medications. And the MED for methadone goes up exponentially as opposed to linearly, and it can put patients in real trouble. So also, you know, is someone being co-prescribed opioids and sedatives, right? There's just some of these really high trigger pieces that if put into place can just be a wonderful way for a care manager to help.
And I would say maybe there was a panicked email that came out yesterday.
There was a what?
A panicked email about the panel because it hasn't been looked at in that way. Yeah, so.
Yeah. Oh, that's exciting that you're doing that work.
It is.
Absolutely.
Let's dig in there. So.
Yeah. No. I mean, one of the great things about having a consistent care pathway is that it's just like, hey, this is now manageable, whereas it wasn't before. So it's like taking something that seems unmanageable and making it manageable. What about you? Anything?
There was a couple things that struck me because we have community health workers that opt in a couple of our housing projects, which is a new over the last year and a half, but really been helpful at stabilizing our housing and results. But the shared language around and the scripting, because there's oftentimes we run a harm reduction program, and so the script to say, you know, we might have a problem. I'm looking at all of your medications that you are on.
Yeah.
Can I go, you know, let's go together to your healthcare provider account to have shared language when they go to Rockwood with the community health worker would be a really interesting approach. Or when our clients go to Chaz to the front door, it's a shared language between our community health workers and our healthcare providers. I think it would really change the outcome because you can't turn one to the other. It's just this is how we do the work. It's the same language. We're all going to talk about it the same way.
You know, what's really exciting about what you're saying is that what I'm seeing is that what the ICHs can do is they can bring other community organizations and some of their staff into some of these conversations so that you can think about the team. Like, you know, in the clinics that we've worked with, the team has actually been the clinic team. But what the ACHs are doing is bringing other folks to the table so that like your community health workers or you as a patient navigator could come and actually take part in one of the organization's team building exercise so that there could be, we couldn't go to all the organizations, but just to understand, like you're saying, the language, what the approach is, how to best work, how best for the community-based workers to actually interface with these kinds of programs. I think that's such a great idea. Did you have any thoughts on this?
I just gotta go.
Oh, okay, that's fine. And what about you all?
Lots of thoughts. I mean, you know, it could certainly see the benefits in a primary care or clinic setting. I was also thinking of, you know, just the behavioral health organizations and how to combine
Yes.
this and what they're doing with such providers.
Yeah.
There's just so many of us that have our hands tied, so to speak, and are really stretched. And it would be, I think, of value to a lot of people to really have a clear path.
Yeah. Yeah, the transformation plan and its differentiation of the opioid work from the integrating behavioral health and primary care was a little bit odd.
Yeah.
So I thought that was curious. There were obviously some reasons for it to be that way, but obviously a lot of overlap. So I think that integration across those sectors would be really important too.
Yeah. I mean, I just think about the fact that you've got the patient coming in.
Right.
Where a lot of times you don't even have the patient, you can't access the patient, you know, to get to this point. So
right.
This is really interesting.
It is.
Yeah.
I think it's a nice program too. I'm really excited to maybe educate some of the providers on what's out there, because I, as provider relations rep, will see numerous cases of patient A was discharged from my practice. Patient A went to here, went to here, went to here. And pretty soon there's no place left for patient A to go because he's been dismissed from every practice. And so it would, to me, it seems like it would be a really advantageous situation to be able to educate providers on opportunities to assist those patients so that they. Yeah. And I see it all the time, you know, and not to say that they shouldn't be dismissed, because like you said, they have to be in some cases, but then pretty soon you get to the end of the line and there's no place left for patient A to go.
Yeah, and patients need care. You may not be able to prescribe their opioids for them, but they need to get care.
And then also the rural communities too. I see a lot of rural providers, and it's just astronomically high in those areas too. And then your provider pool is even more restricted in those rural areas.
Right. Yeah, absolutely. The other thing that I think is really exciting about the ACH opportunity is that across the ACH, so across organizations, if there were ways to kind of know that you were doing the same kinds of things, so that patients weren't leaving one practice and then trying to get into another practice, that would be huge. So, you know, I don't know the degree to which the ACH is going to be able to coordinate everything everywhere, but there are some opportunities, particularly in selected areas that are really high risk, high need areas, and this I think is one of them. So it could be kind of a fun focus for bringing together organizations across an ACH. Again, I don't know enough about how the ACHs are working and organizing themselves. But if there was motivation among organizations to coordinate, you could make a huge difference in a large area, which is pretty exciting. So the next steps for this, I mean, I'm here really just to tell you about this program. And the next steps is really for Better Health Together to decide with partners, like I assume you all are partners, right? Is to decide together whether there's enough interest in this to bring this to Better Health Together, okay? Just like we're working with the Olympic Communities of Health. So I think that the central leadership, I assume, I've been working with Sharice Hope, would be coming to those of you and perhaps to others to say, is this of utility? I assume that you must have meetings in which partners come together and talk about this. So I assume that this would come up as an issue at one of those to make a decision about that. And then if Better Health Together decides to move forward with it, then our team would work with Better Health Together and partners that are interested to actually tailor the program to what your specific needs are. And that might be it. Oh, let's see. Oh, I think that is it. Oh, no, it wasn't it. Oh, no, I guess I'm done now. Right, that was like in the old days they had the, what was it, the cane that pulled you off, but now it's just like the little ringer. This is why I think that I can use my laser pointer to actually change the slide.
Wouldn't that be something?
Thank you very much.
That was
Thank you.
very.
Oh, absolutely.
so much.
So there I am. I have a super easy email, lmb@uw.edu. So feel free to contact me. Those are other contacts too, but I'm probably the easiest person now that you've got FaceTime with me. But yeah, I would just love to talk with you. Even if Better Health Together doesn't decide to move forward with this, if you're interested in this program, please let us know, because I'm very passionate about it, having seen what it can do in sites. And I hope I've been able to help you see the beauty of this approach. It's not really rocket science. It's really about being intentional, having the right people at the table, and just being guided. You know, there's nothing like being guided through a difficult issue to get you to take one step in front of the next, and before you know it, you're all the way across the room or the county or the country.
What was the website? Is it 6?
It's www.improvingopioidcare.org. And I will send Charisse, if I can remember. Is there anybody here who can, are you're from BHT, right?
Yeah, I work here.
Oh, you work here, okay. Never mind. Okay, I'll try to send
With Better Health
Charisse.
Together.
What's that?
With Better Health Together, yeah, I'm with Better Health Together.
Oh, you're, oh, okay, okay. Well, anyway, what I'm gonna try to do is send Charisse the information about telepain, which many of you may already have, but I also want to send you the information about the hotline. Because the hotline, because I was talking to a provider just the other day, and the provider said, I can't get off at noon every Wednesday. You know, that just like doesn't fit with my schedules. But sometimes I've got a question, and I just need a 5-minute, you know, consultation, and that's what the hotline's for. So that's a really cool resource, because you know what it's like. You're seeing a patient, they're like on, you've just inherited someone with an MED of 500, right? And you're like going, and they've been on it for 5 years. And you think they have PTSD and depression, right? And you're like, okay, what do I tackle first, right?
Yeah.
So, you know, it's just it's that moment where it's like you have PTSD around that moment. What am I going to do? You need to talk to somebody. You call a hotline, right? So that's what it's there for, because we all need to work together on this. So, all right, well, thank you so much. And I can stick around if folks have other questions. But I'll get rid of this. Thank you so much.
Thank you.
Great.